Good morning. I think before we start, I would like first just to remind everyone to please silence your cell phones, your smartphones, or any other devices that make noise if you've not already done so. I'd also like to identify the FDA press contact, Andrea Fisher. Andrea, if you're here, would you please signal? Andrea just came in the door over there in green. And I think we'll start by asking the various members of the advisory committee and the consultants in the FDA panel to go around the table here, state your name into the record, and then briefly identify yourself. And we'll start with Dr. Rasmussen down here in the end.
Do again. Mads Rasmussen from Novo Nordisk, industry representative on the panel.
Peter Wilson, Emory University, endocrinologist, preventive cardiology, and public health.
Antoinette Wozniak, Karmanos Cancer Institute in Detroit. I'm an oncologist.
Eric Swenson, University of Washington in Seattle, pulmonary and critical care medicine.
Eva Szabo, National Cancer Institute, medical oncologist, lung cancer treatment and prevention.
Jamie Stoller, I'm at the Cleveland Clinic. I'm a pulmonary critical care doctor.
Maury Shamlin, University of California, San Francisco. I'm an endocrinologist.
Morning, I'm Bill Calhoun. I'm from the University of Texas in Galveston, and my expertise is pulmonary critical care and allergy and immunology.
I'm David Cook. I'm a pediatric endocrinologist at Johns Hopkins University.
Diana Holiaric, consumer representative.
Erica Britton, I'm a statistician at National Institutes of Allergy and Infectious Disease, NIH.
And I'm Robert Smith. I'm professor of medicine and an endocrinologist at the medical school at Brown University, and I'm the acting chair for the meeting today.
Karen Abraham Burrell, I'm the designated federal officer.
Ed Hendricks, private practice obesity medicine, Sacramento, California.
Good morning, Rebecca Killian. I'm the patient representative on the panel. I'm also a type 1 diabetic.
Abraham Thomas, endocrinologist, Henry Ford Hospital, Detroit.
Catherine Flegel, an epidemiologist, Centers for Disease Control and Prevention.
Lokesh Chen, Team Leader, Office of Clinical Pharmacology, FDA.
Mia Paternity, I'm with the FDA with the Division of Pulmonary Allergy and Rheumatology Products.
Lisa Yanoff, Medical Reviewer with the FDA for the DMEP.
Jean-Marc Gauthier, I'm the Division Director for the Division of Metabolism and Endocrinology Products at FDA.
Good morning, Mary Parks, Deputy Director, Office of Drug Evaluation to FDA.
Thank you. Now, for topics such as those being discussed at today's meeting, there are often a variety of opinions, some of which are quite strongly held. Our goal is that today's meeting will be a fair and open forum for discussion of these issues, and that individuals can express their views without interruption. Thus, as a gentle reminder, individuals will be allowed to speak into the record only if recognized by the chairperson. We look forward to a productive meeting. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the advisory committee members take care that their conversations about the topic at hand take place in the open forum of the meeting. We are aware that members of the media are anxious to speak with the FDA about these proceedings. However, FDA will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting topic during breaks or lunch. Thank you. And now I'll pass the microphone to Commander Karen Abraham Burrell, who will read the Conflict of Interest Statement.
Thank you. The Food and Drug Administration is convening today's meeting of the Endocrinologic and Metabolic Drugs Advisory Committee under the authority of the Federal Advisory Committee Act of 1972. With the exception of the industry representative, all members and temporary voting members of the committee are special government employees or regular federal employees from other agencies and are subject to federal conflict of interest laws and regulations. The following information on the status of this committee's compliance with federal ethics and conflict of interest laws covered by, but not limited to, those found at 18 U.S.C. Section 208 is being provided to participants in today's meeting and to the public. FDA has determined that members and temporary voting members of this committee are in compliance with federal ethics and conflict of interest laws. Under 18 U.S.C. Section 208, Congress has authorized FDA to grant waivers to special government employees and regular federal employees who have potential financial conflicts when it is determined that the agency's need for a particular individual's services outweighs his or her potential financial conflict of interest. Related to the discussions of today's meeting, members and temporary voting members of this committee have been screened for potential financial conflicts of interest of their own, as well as those imputed to them, including those of their spouses or minor children, and for purposes of 18 U.S.C. Section 208, their employers. These interests may include investments, consulting, expert witness testimony, contracts, grants, CRADAs, teaching, speaking, writing, patents and royalties, and primary employment. Today's agenda involves new drug application 22472, proposed trade name Afrezza, Technosphere Insulin Inhalation System, 3-unit and 6-unit cartridges for oral inhalation, manufactured by Mannkind Corporation. The proposed indication for this application is to improve glycemic control in adult patients with type 1 or type 2 diabetes mellitus. This is a particular matters meeting during which specific matters related to Mannkind's NDA will be discussed. Based on the agenda for today's meeting and all financial interests reported by the committee members and temporary voting members, no conflict of interest waivers have been issued in connection with this meeting. To ensure transparency, we encourage all standing committee members and temporary voting members to disclose any public statements that they have made concerning the product at issue. With respect to FDA's invited industry representative, we would like to disclose that Dr. Mads Rasmussen is participating in this meeting as a non-voting industry representative, acting on behalf of regulated industry. Dr. Rasmussen's role at this meeting is to represent industry in general and not any particular company. Dr. Rasmussen is employed by Novo Nordisk. We would like to remind members and temporary voting members that if the discussions involve any other products or firms not already on the agenda for which an FDA participant has a personal or imputed financial interest, the participants need to exclude themselves from such involvement, and their exclusion will be noted for the record. FDA encourages all participants to advise the committee of any financial relationships that they may have with the firm at issue. Thank you.
Okay, and we'll now proceed with introductory remarks from Dr. Gauthier from the FDA.
So good morning. My name is Jean-Marc Gauthier, and I'm the Director for the Division of Metabolism and Endocrinology Products at FDA. I want to start by welcoming you to this advisory committee, and I would also like to take this opportunity to thank Dr. Smith and the panel members for their presence here today, and look forward to their discussion at this afternoon's session. The advisory committee meeting was convened to discuss the new drug application for Afrezza. Afrezza is a drug-device combination product consisting of a dry powder formulation of recombinant insulin and an inhaler device. The product was not approved in 2 previous review cycles due to efficacy and device-related issues. With regards to efficacy, 2 of 3 pivotal trials failed to meet their intended primary objectives during the first cycle of review. In the 2 failed trials, the efficacy of Afrezza was also demonstrated to be statistically inferior to standard of care active comparators. In general, interpretability of the phase 3 efficacy results was complicated by high and differential dropout rates and concerns related to potential inadequate optimization of active comparator products. The applicant was asked to complete 2 new trials to establish the efficacy and safety of Afrezza delivered using the device intended for marketing. Mannkind filed the application for Afrezza for a 3rd time in October 2013, with data aimed at addressing deficiencies highlighted in the complete response letters. Over the next 10 minutes, I was asked to review general concepts important to the correct interpretation of non-inferiority trial results. I will do that by covering the following listed objectives. This is important because knowledge of these concepts is needed to fully understand the difficulty the FDA has had with this application and the nature of some of the discussion points reserved for this afternoon's session. All of these concepts are reviewed in FDA's guidance for industry about non-inferiority clinical trials and will be familiar to many of you. I will start by going over what the intent of a non-inferiority trial is, and in so doing, by dispelling a common misunderstanding about these trials. Recall that in a non-inferiority trial, a new agent is compared to a known effective drug. In this first bullet, I review what a non-inferiority trial is not intended for. Confusion arises about the intent of these trials because of their name. The name is a misnomer and suggests these trials establish the new agent is no worse than the comparator drug. To definitively exclude the possibility that the new agent is in fact worse, one would have to demonstrate the new agent is superior to the active comparator. Although demonstration of superiority is one of many possible outcomes in a non-inferiority trial, it's not the primary intent of these trials. So what is the intent of a non-inferiority trial? The intent of a non-inferiority trial, as defined in the guidance document, is shown in the second bullet. And it is to show that any difference between the new drug and the known effective drug is small enough to allow a conclusion that the new drug has at least some effect, or in many cases, an effect that is not too much smaller than the active control. In other words, the intent of a non-inferiority trial is to explicitly show the new agent retains some of the comparator's effectiveness, and in so doing, implicitly demonstrating the new agent has an effect against placebo. So to design a non-inferiority trial, one needs a good understanding of the effectiveness of the comparator agent. This understanding is usually derived from historical trials establishing the efficacy of the comparator against placebo. The historical data should ideally be relevant and applicable to the setting the new agent is to be studied in. This figure summarizes how a hypothetical comparator short-acting insulin has performed against placebo in patients with type 2 diabetes when short-acting insulin was used on top of background basal insulin across multiple placebo-controlled trials lasting at least 6 months. The point estimate of the treatment effect and uncertainty around the estimate across all relevant historical trial is shown in this figure. The hashed orange line shows 0 effect. You see here that the new agent reduces hemoglobin A1c by at least 0.8% across all relevant historical trials. The margin of minimum effect of the comparator against placebo in historical data is referred to as the M1 margin. When designing a non-inferiority trial, you assume that in your new trial, if trial conditions are reflective of historical trial conditions, the comparator will reduce hemoglobin A1c by at least 0.8% when compared to placebo. This assumption, called the constancy assumption, cannot be verified in absence of a placebo arm in your trial. In the next few slides, I will review how this historical data is used to come up with the non-inferiority margin. Again, recall that a non-inferiority trial compares a new drug to a known effective drug. The new drug may have an advantage other than enhancing effectiveness, and it may be reasonable to trade off some of the effect for this advantage. So how would one design a trial to allow a conclusion that the new drug has at least some effect, and that the effect of the new drug is not too much smaller than the effect of the active comparator? To do this, one must select a non-inferiority margin, and selection of a non-inferiority margin requires clinical judgment about how much loss of effect is clinically acceptable. The clinical judgment around how much loss of efficacy one is willing to tolerate will, of course, depend on the seriousness of the condition the drug is intended to treat. The concept of the non-inferiority margin selection will be illustrated in the next few slides. Let's say that you decide it's appropriate to preserve only 10% of the comparator drug's effectiveness for the advantage offered by the new drug. In this hypothetical case, you would design a trial to show that the difference in effect between control and new drug does not exceed 90% of the control's effectiveness. Here, this would be 0.8% times 0.9, which is equal to 0.72%, and 0.72% would be your non-inferiority margin. The non-inferiority margin is referred to as the M2 margin in the FDA guidance document. In this example, you decide it's appropriate to preserve 50% of the comparator drug's effectiveness for the advantage offered by the new drug. In this hypothetical case, you would design a trial to show that the difference in effect between control and the new drug does not exceed 50% of the control's effectiveness, or here, 0.4%. And finally, let's say you decide it's appropriate to preserve 80% of the comparator drug's effectiveness for the advantage offered by the new drug. In this hypothetical case, you would design a trial to show that the difference in effect between control and new drug does not exceed 20% of the control's effectiveness, and here this would be 0.16%. These last examples illustrate that selection of a non-inferiority margin involves, in part, clinical judgment. In selecting a margin, one weighs the consequences of efficacy loss against the theoretical advantage of the product, unrelated to efficacy, to determine the amount of the comparator's effectiveness that should be preserved. For diabetes in general and for insulin specifically, FDA has sought to preserve at least 50% of the effect of the known effective comparator. For a comparator perennial insulin, the FDA has allowed an HbA1c difference of 0.4%, and 0.4% was the non-inferiority margin selected for the Afrezza trials. I would like to move now to issues important in interpreting non-inferiority trial results. These issues impact the reliability of the conclusions that can be drawn from the results of these trials. The first issue was mentioned previously and is called the constancy assumption. As stated earlier, a major assumption in non-inferiority trials is that the comparator response in the trial is in line with the historical response. If this assumption is not met, you could potentially wrongly conclude a drug is effective when in fact it has no effect. Here I show 3 trials where the same active comparator in blue is compared to a new agent in orange. I have hidden the y-axis for now to make a point, but assume the y-axis is the response. You will note that within each trial, the response of the comparator is similar to the response of the new agent, as both the point estimate and the confidence intervals overlap. Since there are no difference between the control and new agent within each trial, these trials would all be considered successful non-inferiority trials, because no difference between comparator and new agent would be detected. Now let's compare all interventions relative to placebo. The response against a placebo is shown on the y-axis. The historical response is shown here. And the margin denoting a 50% effect loss is shown here. You will note that in all 3 trials, the constancy assumption is violated. You can tell that because in all 3 trials, the comparator response against placebo is different than the historical response. If for some reason the comparator was more effective than predicted in historical trials, then you have no issues. you would rightly conclude the new agent is effective against placebo and that the new agent preserves at least 50% of the comparator's effectiveness. If the control performs slightly worse than predicted in historical trials, you may have an issue. You would rightly conclude that the new agent is effective because it retains some effect compared to placebo, but wrongly conclude that the new agent preserves at least 50% of the comparator's effectiveness because it crosses the line denoting a 50% loss of effectiveness. And finally, if for some reason, as in example 3, the control has no effect at all in the trial, you would have a big issue. You would wrongly conclude that the new drug is effective and wrongly conclude that it preserves at least 50% of the comparator's effectiveness. You've heard that trial quality is important when it relates to the constancy assumption. In the next slide, I will review why it's important for another reason. The reason has everything to do with the objective of a non-inferiority trial. In a superiority trial, the objective is to show a difference, and defect in trial conduct that reduce the difference between the active control and the new drug tends to bias the results towards the null, resulting in a failed trial. In a non-inferiority trial, the objective is to exclude a large difference, and defects in trial conduct that reduce the difference between the active control and the new drug tends to bias the results towards the alternative. This would lead to a successful trial. In a non-inferiority trial, enrollment of inappropriate subjects, issues of adherence, withdrawals, dropouts, missing data, losses to follow-up, and protocol deviation may bias towards a conclusion that the drug is effective when in fact it's not. These issues have to be scrutinized when interpreting and reviewing results of a non-inferiority trial. The last topic of discussion is interpreting the results of a non-inferiority trial that you have deemed reliable. For these, we will assume the constancy assumption is met and the trial was of sufficient quality such that bias towards the alternative was not an issue. This graph illustrates 3 example trials with 3 possible outcomes. I have again purposefully compared the intervention to placebo because it is easier to conceptualize the results this way. But remember, you don't have a placebo arm in a non-inferiority trial, so the comparison would be between comparator and new agents only. In these 3 examples, the constancy assumption is met. That is, the active control comparator in blue has exactly the same response as the historical response. In example 1, the new agent is superior to the active control comparator. In example 2, the new agent is slightly worse than the active comparator, but an acceptable level of efficacy is preserved. And in example 3, the new agent is a lot worse than the active comparator, and an acceptable level of efficacy is not preserved. In actuality, in non-inferiority trials, we don't have a placebo control, and what's tested and quantified is the difference between comparator and new agent, conceptually illustrated here. Actual results of a non-inferiority trials will be shown on the next slide. Let me orient you to this slide. You will note that the legend on the y-axis has changed. In this figure, efficacy is no longer reported relative to placebo as it was in the previous figures. Now the efficacy is measured relative to the efficacy of the known active comparator. Each point on the figure represents the difference in efficacy between several new agents and a comparator across 5 hypothetical trials. An example of how the difference is calculated is provided at the lower right-hand corner of the slide. The green hash line denotes the line of no difference. Any point estimate that falls above the line suggests larger hemoglobin A1c reduction in the comparator arm, and therefore worse efficacy in the arm randomized to the new agent. But as long as the upper 95% confidence interval of the difference between intervention remains within the non-inferiority margin, here shown as the red line, an amount of efficacy that you have deemed acceptable is preserved. Any point estimate that falls below the zero difference line suggests smaller hemoglobin A1c reduction in the comparator, and therefore a greater efficacy for the new agent. Let's focus our attention on the upper 95% confidence limit for a moment. In 4 trials, the difference in effectiveness between treatment is no greater than 0.4%. Non-inferiority is demonstrated, and you can be reasonably confident that at least 50% of the active comparator's effect is preserved by the new agent across these trials. You note that some agents preserve more of the effectiveness than others. In trial number 2, the upper limit of the difference excludes 0, suggesting the new agent is actually superior to the comparator. In trial 3, however, the minimum amount of effectiveness is not preserved because the upper limit of the difference crosses the non-inferiority margin. In this trial, you cannot conclude the new agent preserves at least 50% of the comparator's effectiveness, and depending on what the drug is intended to treat, that may not be desirable. Finally, we'll turn our attention to the lower 95% confidence limit in the 2 trials suggesting the efficacy of the new agent is worse. In trial 4, the lower margin crosses the 0 difference line, whereas in trial 3, it excludes 0 difference. This suggests the new agent has worse efficacy than the comparator and that the difference in efficacy is statistically significant. So in summary, the intent of a non-inferiority trial is not to show a drug is no worse than an effective drug, but rather to show that the new agent preserves some of the effectiveness of the comparator drug. By demonstrating a new agent preserves some of the effectiveness of the comparator, one implicitly assumes the new agent has an effect against placebo. This is only true if the constancy assumption is maintained and trial operations do not yield a false positive result. Conclusion reached from non-inferiority trial results can range from superiority to statistical and clinical inferiority and everything in between. In the next set of slides, I'll review some of the discussions that will happen this afternoon, the discussion points that will be tackled this afternoon. The first question deals with type 1 diabetes, and I'm going to go ahead and read the discussion points. Trials in type 1 diabetes demonstrate that Afrezza provides numerically and statistically less hemoglobin A1C reduction than a comparator subcutaneous insulin. Discuss whether the applicant has demonstrated that Afrezza is an effective treatment for patients with type 1 diabetes mellitus. In your discussion, please address each of the following issues. The impact of inadequate treatment optimization in the control arm on efficacy determination. The impact of missing data on efficacy determination. The relationship between Afrezza's clinical pharmacology to its effectiveness as a prandial insulin. Your level of concern with regard to how differences in efficacy will impact disease-specific risks beyond achievement of therapeutic goals. The importance of having an alternative route of insulin administration available. Comment on whether Afrezza is an appropriate substitute for subcutaneously administered mealtime insulin for most patients with type 1 diabetes or for a specific subgroup of individual with the disease. If you believe the latter, describe this subgroup. Discussion point 2 deals with type 2 diabetes. Trials in type 2 diabetes demonstrate that Afrezza is superior to placebo, but is less effective than a short-acting subcutaneous insulin comparator. Discuss whether the applicant has demonstrated that Afrezza is an effective treatment for patients with type 2 diabetes. Comment on the specific clinical setting where this agent is likely to be most useful. Discuss your level of concern with regard to data suggesting a less than dose proportional glucose lowering response and its potential impact on achievement of glucose target in this population. Comment on any other issues discussed in the context of type 1 that you view as relevant to type 2. And comment on whether Afrezza is an appropriate substitute for subcutaneously administered mealtime insulin for most patients with type 2 diabetes or for a specific subgroup of individual with the disease. If you believe the latter, describe this subgroup. Question 3 deals with the pulmonary safety issues with Afrezza. Discuss the pulmonary safety findings in the Afrezza clinical development program. Comment as to whether the pulmonary safety are sufficient to address the pulmonary safety of Afrezza. The pulmonary safety data are sufficient to address the pulmonary safety of Afrezza. Discuss your level of concern with the pulmonary risks. Question 4 deals with the lung cancer risk. Discuss your level of concern with regards to the possible lung cancer risk with Afrezza use. And question 5, discuss any other risks which were not covered in the above discussion points. Questions 6 and 7 are a voting question. Question 6 deals with type 1 diabetes. Based on data in both the briefing materials and presented at today's meeting, has the applicant demonstrated that Afrezza is safe and effective for the treatment of adult patients with type 1 diabetes mellitus to support approval? If yes, please explain your rationale. And if you do vote yes and you have discussions you've stated some of your rationale in your discussion points, this would be the place to fold it in when you explain your rationale. Provide any recommendations you might have for post-marketing studies to evaluate identified safety signals. If no, also explain your rationale, and if appropriate, explain what further data should be obtained before the drug can be approved. Question 7 deals with type 2 diabetes and is it's similarly worded to question 6, so I won't go and read it. But again, we would like you to, if you vote yes, to explain your rationale for why you voted yes. And you can caveat your answer. Again, this drug asks whether or not it should be approved. Thank you.
Dr. Gutierrez, if you could stay at the microphone for 1 second. One of the panel members, Dr. Britton, would like to ask a clarifying question. We just want a brief question and answer.
Yeah, just a brief question on slide 5. I just was confused. Are you saying that you know the M1 to be 0.8, or are you saying hypothetically if it were 0.8?
So
that's slide 5.
Yeah, we have used 0.4, and the way that we calculate, the way that 0.4 was derived was by looking at historical data, which would mean that the M1 was 0.8 technically for prandial insulin.
Okay, thank you. What I would like to ask is for all speakers through the day today, when you step to the microphone, if you would please make sure you don't have with you your cell phone or your BlackBerry or similar device, because that's why we're getting that little bit of interference over the microphone. So if you would just kind of leave that behind. I know that may you feel unprotected if you do that, but if you'd leave it behind when you go to the mic. Now, both the Food and Drug Administration, the FDA, and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the advisory committee meeting, FDA believes that it's important to understand the context of an individual's presentation. For this reason, FDA encourages all participants, including the sponsors' non-employee presenters, to advise the committee of any financial relationships that they may have with the firm at issue, such as consulting fees, travel expenses, honoraria, and interests in the sponsor, including equity interests and those based upon the outcome of the meeting. Likewise, FDA encourages you at the beginning of your presentation to advise the committee if you do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your presentation, it will not preclude you from speaking. And so we'll now proceed to the sponsors' presentations.
Good morning, Mr. Chairman, members of the committee, and FDA representatives. Speaking on behalf of Mannkind Corporation, it is our pleasure to be here today to present Afrezza as a new treatment option for patients with diabetes. I'm John Bedard, Vice President, Regulatory Affairs. We thank the agency and the committee, and also thank and recognize the clinical investigators and over 5,000 patients for their participation in our clinical trials. Afrezza is regular human insulin delivered by inhalation, not by injection. Throughout today's presentation, Afrezza will also be referred to as TI, or Technosphere insulin. The Afrezza system is a drug-device product consisting of pre-filled insulin cartridges and the inhaler. This photo shows a patient taking a dose of insulin with the Afrezza system. Some important features. The device is small, discreet, easy to use, and it will allow patients to take their insulin with minimal interruption of their daily lives. The PK profile of Technosphere insulin is similar to endogenous prandial insulin secretion, with a rapid onset and a Tmax in the 12 to 15-minute range, as you'll see in the next slide. TI provides a formulation of regular human insulin with a unique PK-PD profile. As you can see from this figure, TI's peak insulin levels in blue are in the 12 to 15-minute range, much earlier than the current rapid-acting analog featured here in pink. To differentiate from the rapid-acting analogs currently in clinical use, TI is being described as an, quote, ultra-rapid-acting insulin. To provide a brief background, the original NDA, as Dr. Gutierrez mentioned earlier, was submitted in 2009. It included the data for the Medtone inhaler. An improved second-generation inhaler called Gen 2 was submitted in 2010. In a complete response letter issued in 2011, FDA requested clinical studies with the Gen 2 inhaler. The 2013 resubmission included the data requested by FDA to support the Gen 2 inhaler. The 2013 resubmission will be the primary focus of our presentation today. It addresses FDA comments and requests provided in the complete response letters. Based on input from FDA, we conducted a clinical program to fully characterize the efficacy and safety of the Gen 2 inhaler. Specifically, a pharmacokinetic study comparing Gen 2 and injected regular human insulin was conducted. 6-month safety and efficacy studies with the Gen 2 inhaler in both type 1 and type 2 diabetics were conducted. One of the studies compared the Medtone and Gen 2 inhalers using FEV1 measures to demonstrate comparability. And finally, a comprehensive safety update was done to include all available safety data. The Phase 1 program with TI started in 2001. It was an extensive program that characterized the PK/PD properties of this rapid-acting insulin in healthy subjects and in special populations, including patients with asthma, COPD, and smokers. The Phase 2, Phase 3 clinical development with the Medtone device included randomized efficacy and safety studies up to 52 weeks in duration and 2 long-term safety trials. In 2009, clinical development transitioned from the Medtone study, shown in green, to our second-generation inhaler, shown here in blue. This transition included a pharmacokinetic comparison of Medtone and Gen 2, PK/PD characterization versus regular human insulin and rapid-acting insulin, as well as Phase 3 safety and efficacy studies using the Gen 2 inhaler. Across all studies, over 6,500 patients participated, with over 3,000 patients exposed to TI. You will see in today's presentation that the data from this program has enabled us to demonstrate TI's effectiveness over a broad spectrum of diabetes severity. The proposed indication shown here follows the format used for approved prandial insulins to improve glycemic control in adults with type 1 or type 2 diabetes. Our program supports the following conclusions. Dosing of TI is convenient, and like current injected insulins, it is titratable. There is dosing flexibility, since it can be taken at mealtime or up to 20 minutes after the start of the meal in patients with type 1 or type 2 diabetes. Improvement of glycemic control has been demonstrated for type 1 and type 2 diabetes. Treatment with TI has shown a clinically meaningful reduction in hypoglycemia and a favorable weight profile. TI safety profile is similar to available prandial insulins, with the exception of cough, which is expected and predictable based on the inhalation of a dry powder. Pulmonary safety has been extensively studied and characterized. Pulmonary function effects were shown to be small and reversible when TI treatment was discontinued. Appropriate guidance for safe use has been proposed by contraindicating in patients with asthma, COPD, and chronic lung disease. No cancer signals have been identified in the clinical or non-clinical studies. Overall, the benefit-risk profile is positive and supports the marketing of TI based on the currently available data. These are the external experts who are available to assist us during the question and answer session later today. All of the external experts with us today are paid consultants to the company. None of them have a financial interest in the outcome of this meeting. Our agenda today includes presentations on medical need, drug product and pharmacology, clinical efficacy, clinical safety, and clinical perspective. I would now like to introduce Dr. Janet McGill, endocrinologist and professor of medicine, Washington University School of Medicine. Dr. McGill was an investigator in the recently completed studies TI 171 and 175 and other Technosphere insulin trials. Dr. McGill.
Thank you, John. And thank you to Mannkind and the committee. I'd like to remind everybody that diabetes is a very common illness. It currently affects 8.3% of the U.S. population, of whom about 90% have type 2 diabetes and about 10% have type 1 diabetes. 1 in 3 Americans will have diabetes by 2050 if present trends continue. Of those with diabetes, 31% take or require insulin. These people are young, middle-aged, and elderly, and come from all walks of life. Their needs for a safe and effective insulin therapy are as diverse as they are, yet they have tremendous difficulty achieving excellent glycemic control, as demonstrated on the next slide. While 50 to 60% of the entire population of diabetes patients achieve an A1C less than 7%, two-thirds of those who take insulin fail to achieve this target, and one-third of insulin-taking patients failed to achieve an A1C target less than 8%. Insulin therapy is difficult, and there are many barriers, including clinical inertia, weight gain, injection anxiety, and hypoglycemia. The clinical inertia is primarily a problem that faces clinicians and patients with type 2 diabetes. This Kaiser Permanente study showed that the delay in starting insulin after combination therapy failed to achieve an A1C less than 7% is nearly 5 years. One of the reasons for this delay is the concern about weight gain. The mean weight gain is about 10 pounds in the 7 years starting insulin. Over 50% of patients in this longitudinal study gained greater than 5% of their initial body weight, which is likely to affect their long-term health. Another barrier to insulin injections is the burden imposed by our current insulin regimens. Patients with type 1 diabetes take over 4 injections per day, while those with type 2 diabetes average between 2 and 3 injections per day, and some take 4 or more. The injection burden has an impact on our patients' ability to manage their diabetes. 20% of insulin-taking patients report missing an injection, sometimes or often, and 22% report having to plan their day around their insulin injections. Before we label these patients as non-compliant, recall the Muslim woman pictured earlier who simply cannot expose skin to give an injection in a public setting, or others who work as teachers, miners, or in construction, or who have other life complications. 33% of patients who take insulin report dreading their injections due to injection site effects. However, the biggest problem and most feared effect of insulin is hypoglycemia. Patients with type 1 diabetes experience 2 or more symptomatic episodes per week and 1 severe episode per year on average, some many more. Hypoglycemia contributes to mortality in type 1 diabetes, accounting for 3 to 13% of excess mortality. I've had patients die from hypoglycemia. This is a very real, everyday concern for our patients. In type 2 diabetes, severe hypoglycemia is associated with increased mortality and other problems, such as reduced cognitive function. There are also increased economic costs that are associated with hypoglycemia and many disruptions to daily life. The ADA work group report states that even a 10 or 20% reduction in severe hypoglycemia or 30% reduction in overall hypoglycemia represents a clinically important improvement. As a result of these factors, patients with both type 1 and type 2 diabetes struggle to achieve glycemic control. In the Type 1 Exchange Registry of over 11,000 Type 1 adult patients, the mean A1C ranged from 8.5% in the younger cohort to 7.4% in those over age 65. These patients are treated at 67 academic endocrinology centers where there is access to diabetes education and all kinds of technology, and still all of their needs are not met. Consequently, there is an unmet medical need for an insulin treatment option that is easy to self-administer, has the potential for less weight gain, has less risk of hypoglycemia, and is adaptable to the diverse lifestyles of our patients. I thank you very much, and I'd now like to introduce Dr. Robert Boffman, Senior Vice President for Clinical Sciences at Mannkind. Thank you.
My name is Robert Boffman, and I'm the Senior Vice President, Clinical Sciences at Mannkind. As previously mentioned, Technosphere insulin is an ultra-rapid-acting insulin. I will briefly describe the Technosphere inhalation system for you. Technosphere insulin is an inhalation powder that contains both insulin and fumarole diketopiperazine, FDKP. FDKP is a biologically inert excipient used to form the particles that deliver the insulin to the lung. The particles are ideal for inhalation as they are appropriately sized in the range of 2 to 2.5 micrometers. The Technosphere insulin system is a drug-device combination product. It consists of Technosphere insulin powder pre-filled into unit dose cartridges. There are 2 Technosphere insulin cartridges seen here in the lower right of the photograph. The blue cartridge is pre-filled with 10 units of insulin, which approximates 3 units of subcutaneous insulin, and the green cartridge is pre-filled with 20 units of insulin, which approximates 3 units subcutaneous insulin. The Gen 2 inhaler is the breath-powered device used to inhale the powder. The process for forming Technosphere insulin particles is a pH-dependent process. When the pH of an FDKP solution is less than 6, it forms a consistent and reproducible particle. Insulin is then added to the particle suspension and is adsorbed onto the surface of that particle. The suspension is then freeze-dried, producing the powder that is ultimately filled into the cartridges for inhalation. We see at the top right the patient inhaling through the device which administers the powder into the lung. When the powder contacts the fluid in the lung, which is at physiologic pH greater than 6, it rapidly dissolves and the insulin and FDKP are absorbed into the systemic circulation. The clinical development program was initiated with our first generation inhaler, the Medtone inhaler, which you see in the upper left photograph. More than 10 phase 2 and phase 3 studies were conducted with this device and its cartridge. A second generation device was developed in an effort to improve delivery and ease of use. This device, the Gen 2 inhaler, which you see in the photograph on the right, is more efficient as the number of dosing steps have been reduced from 8 to 4, and it requires 33% less inhalation powder than the Medtone to provide the same insulin exposure. Additionally, each cartridge used in the Gen 2 device requires a single inhalation to deliver powder, compared to 2 inhalations per cartridge required with a Medtone device. Importantly, the Technosphere insulin powder used in both the Gen 2 and the Medtone devices has remained unchanged throughout the phase 3 development program. We see in this figure the serum insulin concentrations following Technosphere insulin dosing with the Gen 2 inhaler and the Medtone inhaler. Because Gen 2 is more efficient, 33% less powder is required for the Gen 2 device compared to the first generation inhaler. A 20-unit Gen 2 cartridge provides insulin concentrations that are comparable to those generated with the 30-unit Medtone cartridge. This comparability is also shown in vitro testing, where both Medtone and Gen 2 were shown to have equivalent fine particle dose, seen here in the table in the insert. The fine particle dose is the metric that most closely corresponds to exposure. When the patient inhales through the Gen 2 device, an airflow is created which delivers the TI powder into the lung. In use, TI is delivered with patient-produced flow rates of approximately 20 to 30 liters per minute. These flow rates generate a consistent fine particle dose, as seen here in the figure. In this video, you will see the inhalation system in use. This volunteer has chosen to put the inhaler and cartridges into a small bag. She removes the inhaler and the blister pack containing the Technosphere insulin cartridges. She will remove one cartridge from the blister pack. She will open the inhaler, place the cartridge into the inhaler device, and remove the mouthpiece cover. She is now inhaling through the device. She is administering her dose. The volunteer will now remove the empty cartridge from the inhaler, close the device, replace the mouthpiece cover, and put everything back into the carrying pack. She has now taken her insulin dose. Technosphere insulin inhalation powder has been evaluated in an extensive and comprehensive non-clinical program. Both the Technosphere particles, that's FDKP alone, and the Technosphere insulin powder were tested in this program. Evaluations from the 2-year rat inhalation carcinogenicity study and the 6-month study by subcutaneous administration in the transgenic mouse found no evidence in either species of carcinogenicity or metaplasia due to TI inhalation powder or the Technosphere particles. In addition, there were no proliferative changes as noted by pCNA staining in the lungs of animals in the 2-year inhalation rat carcinogenicity study. A number of pharmacology studies were conducted, including comparative pharmacokinetics, drug-disease interaction, and co-administration with compounds dosed via the pulmonary route. Except for a modest change in asthmatics, the PK profile of TI was essentially unchanged in these evaluations. The excipient, FDKP, underwent a thorough QTC evaluation at therapeutic and supratherapeutic doses using moxifloxacin as the positive control. There was no effect on the QT interval. Technosphere insulin is described as an ultra-rapid-acting insulin because its onset of action is more rapid than what's observed with rapid-acting analogs. Here we see the pharmacokinetic profile of Technosphere insulin that's in the squares with the blue line. The peak concentration occurs typically between 12 and 15 minutes, and insulin concentrations return to baseline by about 180 minutes. However, the rapid-acting analog does not peak until about 45 to 60 minutes and has circulating concentrations that last well beyond 5 hours. For comparison, the time to Tmax for regular insulin is even longer, at roughly 120 minutes, and circulating concentrations are measurable out to 7 to 8 hours. The ultra-rapid absorption and shorter exposure time translates in these same subjects to a corresponding pharmacodynamic profile. On the right, we see the glucose infusion rate curves during a glucose clamp. The peak effect of Technosphere insulin is at 30 minutes and lasts to about 4 hours, whereas the rapid-acting analog does not have its peak effect until almost 2 hours after dosing, and again, because circulating concentrations remain at 300 minutes, the pharmacodynamic effect lasts 5 to 6 hours. And again, for comparison, regular insulin has a GIR max typically at 240 minutes, and the glucose infusion in this model runs often well beyond 8 and 9 hours. Historically, the need for additional basal insulin was demonstrated when moving from regular insulin to rapid-acting analog. The data presented here suggests that in a basal bolus regimen, when switching from a rapid-acting analog to the more rapidly absorbed Technosphere insulin, additional basal insulin may be necessary. Technosphere insulin dose proportionality was assessed in a glucose clamp study with 36 subjects who received 4 doses of Technosphere insulin, 10, 30, 60, and 80 units, administered in a randomized crossover design, as well as 15 units of subcutaneous regular human insulin. We see in this figure the insulin concentrations produced by the different TI doses and the regular insulin dose. The increase in the area under the insulin concentration time curve for the TI doses was linear and directly proportional to dose, seen here in the inset. The same was observed for the maximum insulin concentration. The intra-subject variability in this study was 34%, which compares to what's been reported frequently for regular human insulin of about 30%. The pharmacodynamic response of TI is driven by concentrations not in the systemic circulation, but by concentrations in the effect compartment, the liver, muscle, the adipose. And the model that best describes the action of insulin, actually all insulins, is the Emax effect model. The lower figure displays the modeled pharmacodynamic response for each of the 4 doses administered in that dose proportionality study. We do see a disproportionate increase in effect as we increase the dose. However, even as we approach the Emax, an additional effect is seen due to the higher doses having a longer exposure period. In summary, the Gen 2 device is an easy-to-use inhaler with reproducible insulin delivery. The Afrezza system has undergone extensive evaluation in both non-clinical and clinical pharmacology studies. Technosphere insulin inhalation powder produces a more rapid onset of action and of shorter duration than what is observed following subcutaneous rapid-acting analogs or regular human insulin, and has consistently demonstrated that rapid absorption. Proportional insulin concentrations were demonstrated over a wide dose range, and, like all insulins, its pharmacodynamics is described well by the Emax model. I would now like to introduce Dr. David Bregman, who will present the efficacy of Technosphere insulin. David.
Good morning. I'm David Bregman, Director of Clinical Development at Mannkind, and I'll be presenting clinical data that support the efficacy of TI. The presentation will start with discussions of 2 trials in type 1 diabetes. Trial 171, which assessed the efficacy of the Gen 2 inhaler over 24 weeks, is the focus, with supportive information from Trial 009, which assessed the Medtone inhaler over 52 weeks. For each trial, design and primary efficacy endpoints will be presented, followed by secondary endpoints together. For type 2 diabetes, Trial 175, which assessed the Gen 2 inhaler over 24 weeks, is the focus, with supportive data from Trial 102, which assessed the Medtone inhaler over 52 weeks. Finally, I'll provide data on hypoglycemia for the type 1 and type 2 diabetes trials together. The primary endpoint of all trials is the change in HbA1c, or A1c, from baseline to the end of the randomized treatment phase. Secondary efficacy endpoints to be discussed are % of subjects achieving A1c less than or equal to 7%, 7-point glucose profiles, and body weight. While hypoglycemia was considered a safety parameter in the trials, it is discussed here given its close association with insulin effectiveness. We'll start with type 1 diabetes. Before presenting the detailed design of Trial 171, I'd like to highlight some key points. The trial was designed with input from the agency to assess the efficacy of TI using the new Gen 2 inhaler for type 2 diabetes in a non-inferiority design. The comparator is a standard of care injected prandial insulin, insulin aspart. A switch trial design was chosen. All subjects were required to convert to insulin aspart prior to randomization. This occurred at the beginning of a 4-week pre-randomization period when basal was being optimized. The patients who were subsequently randomized to TI need